We want to welcome everyone to tonight's free member webinar on ophthalmology call confidence, building a team approach to safe, effective emergency coverage. And tonight we have a moderator, Dr. Rapuano, joining us. So exciting. He has no financial relevant relationships to disclose. So I'm going to go ahead and turn it over to Dr. Rapuano. Thank you.
Thanks, Jess. Thank you for joining the webinar. I'm Christopher Rapuano, the current president of the AAO. My focus this year is to shine light on the worsening problem, the lack of ophthalmology emergency room and hospital coverage. The reasons are many and go back years, but they include the fact that many ophthalmologists only operate at ASCs now and are no longer on hospital staffs, so don't have to kind of take a call kind of per hospital bylaws. There are also some negative misconceptions about taking call, which we're going to dispel some of those today. I understand this problem can't be fixed overnight, but I and many of the staff at the AAO, especially Sean Hillier and Dale Fajardo, and another excellent group, ASOT, the American Society of Ophthalmic Trauma, are trying to kind of help this problem. One way is through improved clinical education, especially on the AAO's One Network and Education app and on the ASOT website. Another way is helping ophthalmologists negotiate with hospitals. And another is kind of the focus tonight. How can your office staff help you and decrease the burden of being on call? We've had and continue to have webinars throughout the year on a variety of topics dealing with being on call. I'm happy to have you on the call tonight. I want to thank OMIC for their generous support of this webinar. I'm thrilled to have three excellent speakers this evening. Dr. Grayson Armstrong, Director of Ophthalmology Emergency Services at Mass Eye and Ear. He's also on the board of ASOT, and he and I have done numerous programs together. Kristen McKeever is the Clinical Practice Coordinator at Virginia Eye Institute, a very large practice based in Richmond, Virginia. And Jess Schroeder, who's the Manager of Coding and Practice Strategy at the AAO. Before joining the AAO, she was a practice administrator in North Carolina. Before that, a billing expert and trainer at Wilmer. Thank you for being here, and I'll hand it over to Jess.
Thank you, Dr. Rapuano. We have a great night planned, and we just really want to focus hard on how this really is a team approach to ensuring our physicians are able to take call, and we have all of our bases covered. So it takes a lot of preparation and a lot of communication in order to execute a proper call protocol. So, as an administrator, I was involved heavily with making sure all of the contracts were in place, that we have processes in place and workflows. And there's a lot of teamwork involved in ensuring, again, that these patients are getting the care that they need. So tonight we'll have Dr. Armstrong speak on physician on-call preparation from his perspective at the trauma center that he's in. We'll have Kristen speak on building your care team and how to make sure that your clinical support is well-trained and ready to take call. And I'll wrap up the presentation with how I'm supporting my physicians through workflows protocols, and again, ensuring Kristen has the time needed to train her staff. We will have lots of resources available for you all. This first one is a QR code for the on-call toolkit. We encourage you to take advantage of these resources that you have at your disposal tonight, and you'll see lots of QR codes throughout the presentation. So at this time, I'm going to turn it over to Dr. Armstrong on the physician on-call preparation.
Thank you, Jess, and thank you all for being here. Thank you, Dr. Rapuano, for highlighting this important topic. Taking a call for any institution is a large part of what ophthalmologists and all physicians across medicine do, but it's a team approach and we don't do it alone. And I'm so glad that we're able to talk about this in that setting today talk about how team members can support one another from the physician side and from the practice management side to make this a reality and decrease the burden, as was talked about before. When you're thinking about taking call, you can kind of divide this into two major buckets. You can take call for hospitals and emergency departments. This is generally outside of your own practice. I am at a big academic institution that has its own eye emergency room, but that is not common in the United States. Most of us would be taking call for an emergency room in the community and supporting the community in that way. It's also subdivided into taking call for your own clinic or for your practice group. And so these are two very different things, and I'm going to talk about each one separately. And the first one, next slide, is taking call for the hospital and emergency department. Next slide. So I would say that this is one of the large practice responsibilities and professional responsibilities that we as ophthalmologists and physicians have to our patients and to our communities. We know better than anyone that only ophthalmologists know and understand the eye, and only ophthalmologists know how to manage eye emergencies, both medically and surgically. And if we aren't there at the bedside to help take care of these patients, then no one will be. And I do think that there are major risks of not having physicians and ophthalmologists present for eye trauma care and on-call care. And it is our duty to provide this high quality care to patients who are in need. The expectation for taking call is to have urgent availability for in-person care or close ambulatory follow-up. And so you don't have to necessarily see them all the same day, but you need to at least create systems so that you can see them in a timely fashion. And if you do see trauma, you need to provide damage control ophthalmology. What that means is that you need to stabilize the eye, close the eye if it's an open globe, but generally you need to just stabilize the eye, keep it safe so that you can refer that to a subspecialist if necessary to provide the definitive reconstructive care. And so it is appropriate in that first moment. I want to stress this. It is very appropriate in that moment at the first point of contact to stabilize the eye, keep it safe, and then make sure that it's ready so that in subsequent hours, days, or weeks, that can be reconstructed in a way that will maximize vision. But of course, there are challenges to taking call in this way. There's an unpredictable consult burden, and there's also the fact that this could conflict with your scheduled patients in your clinic, for your surgical schedule, and your home life. Next slide. But that's why it's important to come prepared. If you're coming to a hospital or an emergency room who needs call coverage, you need to be able to negotiate and come ready. And so you might want to find a group of docs to join in on the call burden instead of just going in alone as a single doc, because being on call 24/7 can be tough. It is important to go into that conversation with many aspects kind of pre-prepared in the conversation. You want to negotiate the time it's going to take you to respond and how much time is allowed for you to respond so you don't have to call back necessarily right away. And also malpractice coverage, who's paying for that for this scenario and after the fact for tail coverage. You need to have an agreement for in-person versus outpatient follow-up for certain conditions so that if you are getting called, then it's appropriate and it's understood that you don't have to see them all in person. You should probably create workflows for the initial ophthalmic workup for the emergency department and for the inpatient providers. Make sure that they're trained and ready to check visual acuity, intraocular pressure, get CT scans if the patient has trauma prior to calling you. So you have more data, more information so you can make a better decision at the point of care and at that first touch point. You wanted to make sure that you have available OR time for emergency cases. This is a sticking point at some institutions, so really come in prepared to argue for that if you need it. Make sure you have the appropriate equipment for patient evaluation and management in the inpatient and the emergency room side. And make sure that in the OR and in the emergency room, you have appropriately trained staff. You don't want to show up and them not understand how to use the vitrector machine or the phaco machine or know where the Tenno nylon is, for example. Next slide. And so we have created a list of the required and recommended equipment that's necessary in the emergency room and in the operating room. If you go to the QR link here, and it's also linked out in the chat, it gives you a list, very detailed, of some of the recommended equipment for the operating room and for the emergency room inpatient setting for the hospital setting so that you can take care of these patients appropriately. This is just a small subsection of the operating room equipment and your tray, and then a small smattering of some of the stuff you might consider for the emergency room. Next slide. You also want to make sure that you're building a team and fostering a team-based approach to improving the care and reducing this burden. And so, as I mentioned before, work with the emergency personnel and inpatient teams to discuss these expectations ahead of time, the time to respond to consults, and the workflows to ensure timely outpatient follow-up. Who do they call? How do they get in touch with your practice, for example? Educate the doctors and nurses in the ED and the inpatient setting to capture these ophthalmic vitals in history. You can be a part of that educational conversation. You can create resources and tools, sometimes videos, and sometimes even webinars like this one. They can help train them so that they can be up to speed and provide better care for your patients on things like visual acuity, checking pupils, intraocular pressure, obtaining CT scans, keeping the patient NPO when appropriate, and wearing an eye shield for major trauma. Educate the OR nurses on ophthalmic equipment as well. Sometimes we've seen people do yearly or every 6 month in-service education on the surgical tools and equipment for the ophthalmic emergencies because it's not necessarily common for them to use these. And so it's nice to be able to walk around the OR, make sure all the equipment is there, make sure it's ready to go, and make sure the OR team knows what they are using. Next slide. But let's talk about taking call for your clinic or group. This is probably hitting close to home for most people. This, again, is one of our professional responsibilities as ophthalmologists. You need to provide timely care for urgent issues among established patients. And ophthalmology practices generally have a legal and professional duty to provide a reasonable pathway for timely triage and care of our patients. The expectations here are that we establish reliable methods for patients to reach out to us. This can be as simple as calling the front desk, having a call center associated with your practice, having residents and fellows around who are taking the calls, or others. But you can get creative. You just have to have a method in place and make sure that it's reliable. You need to create a reliable system for triage, escalation, and same-day urgent appointment scheduling as well. This is important to do both during business hours and also during off hours, so that if something gets called in and it's an emergency, it's triaged appropriately. You should probably arrange for coverage to provide timely clinical care for urgent issues that arise, even if you can't be the one to take care of them, and make sure that clinical decision-making starts during the telephone call and that people understand that. When that patient calls in with an urgent issue, that point of contact is the first point of contact of clinical care. So when you're addressing these concerns and creating a reliable on-call system, you need to make sure that you're establishing systems that can manage these inbound concerns. So if your in-basket is overloaded, then you might need to turn it off or find a different method, or make sure that someone is covering the in-basket all times, for example. And if you're providing thoughtful intake, then it helps in the back end as well. So thoughtful creation and setting up the system is important. Make sure that clinical people, again, understand that clinical decision-making starts during the telephone screening, but create protocols so that non-clinician staff are the ones who help address the common concerns when they call in. You can tell them, for example, if they have flashes floaters, then they should definitely come in. If it's someone with a red bump on their eyelid and it's been there for like a week, maybe that doesn't need to come in right away. But if there are concerns and if people don't understand, you do need to create an escalation pathway to ensure that a physician like yourself ultimately determines the disposition of the patient when necessary. You want to make sure that your staff are not necessarily making these decisions on their own. They can bump it up to you to make the final decision. Poor handling of initial calls can lead to harm and liability, and creating the system in a reliable, manageable way is incredibly important. Next slide. And so again, build a team. Whether you're in solo practice or a large group, find a group of doctors willing to cover one another and share the load of patients that need to be seen, because not everyone can be there all the time. And build access into your practice. Build it into the structure and the backbone of your practice. Instead of forcing patients into overflowing clinic schedules, consider blocking off appointments and designating them for on-call patients ahead of time. That way your staff have a place to put them and patients don't feel like they're burdening you. Make sure that you're not feeling like at the end of the day, you saw too many patients. You have this built into the DNA of the practice. Provide ED doctors with a pathway to easily schedule these patients and follow up patients. And sometimes creating a reliable referral pathway is really the only option you need, because a lot of these patients don't have to be seen same day. They just have to be getting in timely fashion to see you. And when in doubt, always see the patient. Communications with patients should always be documented. Make sure that you and your staff understand that any telephone call, any patient encounter should be documented in the EMR. Next slide. So in short, create a system for your practice where all urgent and emergent calls from established patients receive timely clinical triage. Unlicensed staff are not making clinical decisions, and there are clear protocols and pathways in place, but if they're not sure what to do, red flags can be escalated to you as the ophthalmologist to make the ultimate decision. Patients who need in-person care are directed to the appropriate site without delay, and then every call is documented and closed-looped. Next slide. Now I'm going to talk quickly about some of the on-call resources that ophthalmologists and your staff can use to make sure that you're ready and prepared when these issues arise. We'll talk about the clinical and surgical preparation and education, and also billing for on-call care. Next slide. We'll talk about clinical and surgical preparation and education first. Next slide. So the American Academy of Ophthalmology has a ton of resources that have been kind of collated thanks to Dr. Rapuano, Dr. Rob Wanna did an amazing job at trying to make sure that all of this is in one location on the website. And so this is called the Call Confidence Resources, and the link is here. Next slide. There have been multiple webinars, not just this one that you're listening to today. Some of them are more clinical in nature and talk about clinical management of these urgent issues. Here you can see Dr. Rapawano giving one of those talks. Next slide. We have wet lab education at some of our meetings, such as the American Academy of Ophthalmology meeting. You can see some of the team from the American Society of Ophthalmic Trauma here on the right-hand side at one of the wet labs at the last AAO. Next slide. And of course, already mentioned, we have the American Society of Ophthalmic Trauma. And in 2026, we'll be hosting another meeting, and we hope to have some wet labs there. And if not, then we'll definitely be having them in 2027. But these are pictures from prior wet labs, and the successes there go on to help the communities in which those physicians serve. Next slide. There are also video-based educational resources. Here you can see a video-based surgical curricula for open globe management. This is a whole chapter with videos focused on corneal wounds, and there's scleral wounds as well on the next slide. And then if you go one more slide in, you can see that these videos are peer-reviewed and managed to show details of management of different types. So this is talking about different slip knot techniques. There are others that talk about scleral repair, how to do a peritome, all the basics, so that at the point of care, when you're taking care of these patients in an emergency setting and you're a little bit nervous or you haven't done this in a little while, you have these resources at your fingertips. Next slide. These videos are available in PDF format as well, with all of the details and the script written out. Next slide. And it is divided into 6 chapters. These are open source and free to access, and you can see the 6 links to them here on the screen. Next slide. As mentioned, there are a ton of web-based educational materials, such as the webinars with expert faculty through the Academy. Next slide. There are ebooks that are available for free. This is called The Open Globe. You can download it to your computer, your iPad, or your phone. We also have online courses with questions so that you can test yourself and your knowledge. Next slide. And there are many textbooks that are available that can be used to help educate yourselves and your teammate on ocular on-call emergencies and ocular trauma. Next slide. And so in terms of billing, next slide, there are many resources again on the American Academy of Ophthalmology website. If you go to the coding news and just click the trauma coding portion of that, there are many, many articles that talk about various coding and management tips when you're seeing patients on call or for trauma care. Next slide. Here you can see a whole bunch of QR codes that take you to different aspects of the AAO's website. You can see things like telemedicine, because telemedicine can be appropriate for initial triage and management of some conditions, coding for ocular trauma, an AAO Ask the Experts about coding, E&M webpage and how to choose between E&M and I codes, and surgical coding. There's also CodeQuest, which is offered by the Academy. And of course, the Fundamentals of Ophthalmic Coding is a book and also is educated in those CodeQuest courses. Next slide. And so at this point, I tried to get through as much as I could in a short time frame, but I'm happy to take any questions. And I just really want to thank you all for being here today, and again for the opportunity to speak with you.
Grayson, that was great. I don't see any questions, but we're happy to have people put questions in the Q&A. But I wanted to just kind of have you just elaborate on kind of the damage control ophthalmology and kind of not in my specialty. I think a lot of doctors are like, oh, I'm a cornea specialist. I can't be on call. You know, what if a plastics case comes in, or what if a retina case comes in, or something like that? How does one handle that?
It's a great question. It's a 2-part answer that I'll give. First, just remember that we're doing this care for patients in a team-based setting. You don't have to do this all yourself. If you're on call, yes, you may be the first point of contact or the first phone call that goes out for the eye emergency, but that doesn't mean that you have to be the one that's ready and willing to fix everything that comes in. For example, if you're a cornea specialist, you may not have the tools or the skills to take care of a peripheral retinal detachment, and that's okay. You just have to create a system where you are set up for success with retina surgeons, plastics, pediatrics, etc., so that when the time comes, you can refer those patients out. But What do you do when you first get that call? What do you do when you show up for that first call? Well, the first most important thing is to see the patient and diagnose the issue. That way you can get to the patient to the right place at the right time. But damage control ophthalmology is an idea that you just need to stabilize the eye, make sure that that patient is not going to further lose vision. And so in the case of trauma, that would be closing the globe without necessarily doing a vitrectomy or lensectomy, et cetera. You can help repair the eyelid, but you don't have to necessarily worry about the fractures yet. And then you just get that patient to the right place at the right time within the next couple hours, couple days, couple weeks. That's the idea behind damage control ophthalmology.
Great. And I also wanted to just emphasize your point about documentation. It's critical that when your staff gets a phone call, or your resident or your fellow gets a phone call, they document all those in the chart. And the other thing I think was really important was that your staff is taking a lot of these phone calls. I mean, you can't sit there on the phone and take every call from every patient that comes in. The doctor can't do that. So the staff needs to be very well educated on the protocols. And OMIC does have kind of a script of kind of what or a kind of a paradigm of what to do with what certain things. So glasses and floaters kind of get this, come in right away, as you said, and other things. Red eye, and the urgency to see when patients should be seen. There are a couple of issues that are kind of more important and need to be escalated. One is post-op patients. Your staff should really have low threshold to talk to the doctor about what's going on with a post-op patient. A patient who's called numerous times. They've called once and said, I have a little red eye. That's one thing. They keep calling back. That should be escalated or told to come in. And then children. If a parent is calling about a child, be extra careful and cautious. If a parent calls back with a concern about a child, that's something that's also critically important. The parent's concerned, you should be concerned too.
I totally agree. And creating that expectation from the outset with your practice group and all of your staff is key. Make sure everyone is on the same page and has a resource so that they can refer to that when those questions arise, and they aren't having to necessarily going to find you in the OR or between patients to try to get these answers all the time.
Great. Terrific job.
Thank you.
Thank you. On to Kristen.
All right. Well, see if my stuff's, there we go. Hi, I'm Kristen. Thank you everyone for being here. Go ahead to the next slide. So it is incredibly important when you have technicians taking call or a practice participating in technicians taking call, that you have everything you need at your fingertips. Your equipment and supplies, the correct staffing. Your staff obviously needs to be educated, and communication is incredibly important. Next slide. Equipment and supplies in the office, obviously lasers, B scans, can't see in an eye, syringes and needles, all the drops, bandage contact lenses and lens kits. For the hospital, almost like in a go bag. But I think, most of these things are in a exam room in an office, but for a hospital, occluders, the lenses for the physicians, fluorescein strips, lid speculums, jewelers, of course, patches, all the drops. Consent forms are so incredibly important for documentation. And again, bandage contact lenses. Next slide. So with your staff, I know in my practice with technicians that do call, you have to be certified, COA or above. Length of service definitely plays a part in the skill level. The longer you've been a technician and the more you have seen, the more knowledge you're going to have. I take call for several different types of physicians, several specialties. And the benefit of doing that is I learn more. Even as long as I've been doing this, I still get to learn more working with different physicians. Your practice has to decide how long is your call shift, how do you want to schedule your technicians, and then obviously for compensation, there are state guidelines, and our practice decides on which physicians want to participate in having technicians take call. Not everybody participates in that. Next slide. For your staff training, it is important to identify the training needs. Where is somebody lacking in strengths, so that you can bring them up to par? You want to prepare the staff members in advance. You need to have a toolkit for them, just like you would for the physicians, but you need a knowledge toolkit where it's good to provide the resources for them. Having a binder that goes through all the most critical calls, not even the most critical, all of the calls that you get, but how to handle each one. Like Dr. Rapuano said, if you get, somebody that's called more than once, or they're complaining of increasing redness and light sensitivity, and, those are, especially if they're post-op or post-injection, those are very important to get in very quickly. Next slide. This is, you wouldn't believe how often we get calls on this. With opening a clinic on the nights and weekends, where the light switches are. That is, and the alarms. It is so important for your team, your staff, to know where those items are. Otherwise, you're running around in the dark. And I've done that before. And that was a lesson learned. Alarms, I have other team members that, the manager was called because the alarm went off. So these are things to think about that, may not always be in the forefront of your mind. Unlocking appropriate doors, and that kind of goes along with the alarms. Preparing the clinical area, so having everything ready for the doctor. If you're going to be working with a physician, getting there before them and having everything ready for them. Like the exam room, having your drops and supplies right there at their fingertips, and having all the equipment turned on. Also, the administrative tasks. This is really important also. Being able to copy insurance cards or fax something to another practice or a hospital. Getting a patient registered. Consents, again, surgical consents, procedural consents, all that paperwork is very important. Next slide. Advanced preparation. So separate on-call training modules. This is really great, having people shadow registration, shadowing surgical coordinating, because this gives you a better grasp of the information those people need, even if they're not there, so that you can obtain the information that is required for them to do their job on the back end. Sign off from supervisor or lead. Call service contact information. This is a big one. You need to make sure that they have the correct information for whoever is taking call. So before that call time starts, sometimes it's good to check in to say, hey, just want to make sure it's my number you have for call tonight. And then an overview of expectations leading up to call week, a broader view of who's working, what hospital possibly. Next slide. So the on-call binder, like I mentioned before, with the standard operating procedures, how-to manuals are great. I think even in an emergency situation, it's good to be able to look back and make sure you're crossing all your T's, dotting all your I's, you know, that you have all the right things there for a doctor. Like if you have an endophthalmitis and you know, have to inject and, you know, send off a culture, you need to make sure you have everything. Physician specific post-op instructions. We have a link where because a lot of doctors do it differently, and we want to know, you know, what the patient is doing compared to what they should be doing when they call. And then triaging for specialty clinics. This is a big one. And even I'm retina, have been for years. And so sometimes a cornea thing will pop up and I will reach out to a cornea technician, and it's relaxed enough here that I can do that. I can ask a simple question, but we also have the manuals at our fingertips to go back on. Electronic resources like the how-to videos are a good way to prepare your staff, and a share drive. I love pocket cards. I think it's a great quick reference for physician preferences, and then commonly used drops with the cap colors, because most of the time the patients don't know the names of the drops, but they can tell you the colors of the tops. Next slide. Communication, call documentation. This is so big. One of the biggest things is getting the date and time of the call, obviously their name, date of birth, and phone number, because sometimes they're not an established patient. And if I'm taking call from home, I'm not registering a patient, because I'll take call overnight for a physician and we're not coming to the office. And if they're not already registered, I just have to take generic information and then give that to our call center the next day. The chart documentation, leave a detailed description of the complaint and the action you took to pass along to the physician in detail. You know, this is what the patient complained of. This is what we discussed. Were they reassured after? You know, they're going to follow up tomorrow. You know, make sure all of that is documented. And then, of course, patient follow-up. Get the information to the billing team or bill it properly in the computer. Follow-up appointments are a must, or at least, you know, following up with a physician document-wise, and then allowing them to schedule that follow-up. Any questions for me?
Great job, Kristen.
Thank you.
Let's see. We have a question. I think we should be careful saying technicians are taking call. In reality, trained staff are triaging patient calls, but not making medical decisions. If a technician takes call, why can't an optometrist take call first? So I think that's a very good point. I think that we often have staff members, whether they're front desk staff or whether they are on-call technicians, who are actually kind of the first line, and they are then kind of using a protocol set up by the physicians to triage patients. So that's
for us, right? Us specifically, we do a weekend and night call for our partners, but during the day, it's going to come through the call center, and then they don't triage anything. They send it to whatever physician is on call that day, and then the certified technician, usually the practice coordinator, is the one that triages for the physician and gets them in.
Right. So I assume that if a technician is on call at night or a weekend, there's also a physician on call in case there's something that needs to be done.
Yes. Okay. We're just taking the calls for the physician.
Right.
And if there is something that is above our knowledge or that we have questions about, we can just reach out to the physician.
Right. So I agree. I think that's very important. You mentioned kind of turning the lights on. The other thing that is important is turning on the computer.
Yes.
I mean, sometimes, when I go in, my technicians have kind of done everything for me, but occasionally if I'm going in happen to be there on my own, I don't necessarily know how to turn on the computer in every single office or area.
Right.
And the other thing that you mentioned was kind of that I'd like to mention is taking call from an emergency room. If your doctor is on call and the doctor and the patient comes for the emergency room and the doctor says, okay, they talk to the ER doc and they think everybody agrees it doesn't need to be seen emergently. The doctor doesn't need to go in to see the patient. The patient can come to the office the next morning. It's critical that the doctor relay that information to their office staff and says, okay, office staff, my patient, this patient from the ER, Mrs. Smith, is coming in tomorrow morning, and we need to see Mrs. Smith. Because if I'm on call for the ER, I am responsible. And there have been cases I know of where Mrs. Smith has come to the office and the front desk says, oh, we don't take your insurance, go away. And that is not acceptable.
Can't do
Or
that.
they say to Mrs. Smith, oh, your appointment was at 9 a.m. and you're here at 11, you have to go away. No, you will see them no matter what insurance they have or don't have, whether they can
Right.
pay you or not, no matter what time they come in. That is your responsibility if you are on call for the ER. You have a duty for a call for the ER. And that just needs to be conveyed. I mean, the doctor may believe all that, but if he doesn't convey it to the staff doesn't know. So that's another kind of very important thing. Okay, great. Let's move on to Jessica.
Awesome. Well, I'm excited to carry on the conversation and just discuss how I would support my team through this whole on-call process. So I'm going to speak a little bit more on the private practice model. Much like Kristen, we had a support staff, so a technician, quote unquote, on call with the physician. We call it on call because they're supporting them through their time that they're on call. Our call rotation was Monday through Sunday. So a technician was, there to support them through that time. We also supported our hospital. I came from a retina-only practice, so we did not take general ophthalmology call as we had ophthalmologists in the community who do that for our small hospital, but we did support retina ER call and we're there if needed. There is one other retina group in our town, so we split with them based on the number of physicians per practice. So this is just the way we covered it in our practice. So just wanted to kind of go into that. So again, this is a team approach. We have a large staff of people there supporting our physicians and supporting one another and caring for our patients who have an emergency. So it may start with triage or even our front desk team and move on throughout our physician and clinical teams. Our billing team and surgery coordinators are there to support on the back end, as well as our appointment desk. So everybody plays a role when we're seeing an emergent patient. So we have a few different scenarios, right? So we have emergencies during office hours. We have emergencies in office, but after hours, and then again, emergencies for a hospital call. So these are all handled a little bit differently. So I'm going to just talk through those scenarios. So during office hours, we have just on our general phone tree, if you're having an eye health emergency, to click the prompt for our triage person. So this is in our practice, actually, a former technician who has worked in ophthalmology for over 20 years. So she has a lot of knowledge and has a great understanding of, what is emergent and what is not. This QR code leads you to the AAO site for coding for ocular trauma, but there is also a section of that page that goes into a couple of the the decision trees that Dr. Rapuano was talking about earlier, where if this scenario comes up, such as flashes and floaters or eye pain after a procedure, this might be more emergent than maybe, a sty on the eye. So it kind of talks through those items. So that's a great resources to have for your staff. So a big part of this workflow for our practice was communication to the on-call physician. sometimes they're in the OR already that day, so there has to be a backup for, okay, the on-call physician is not actually in clinic at this moment, so what's the backup for that? In some of these provided resources, you will see those types of scenarios. And for us, the communication goes out to the teams that are on in clinic that day and who's available to take them. And a big part of this is, have you planned for it? And Dr. Armstrong brought this up in his talk. Like, have you planned for those work-in appointments in your clinic template? So it's really important. I know from a retina standpoint, we're always getting those calls late morning. So we're needing to add a patient on in the afternoon who's having an emergency. And you're thinking about this bogging down clinic. What if this patient now is going to take up resources for needing an FA or needing lasers or whatever it may be? So, it just kind of can easily snowball into a jam in your afternoon. So it's important that you try to plan for it as best you can. So we did typically have work on slots in the afternoon. And if you're someone who knows when the call week is for the physician, you can easily build in more of those on their call weeks and accommodate those work-in slots or work-in patients a little bit easier. So in office, but after hours. So for all of us, we have to figure out, how is that patient going to get in touch with the physician that is taking call for the practice? So you have to figure out that workflow for your call line. Do you use an after hours call service? Is it a prompt that automatically forwards the call to the physician who is on call to their cell? There's multiple ways to handle that. If you have an IP phone system, it makes it a little bit easier to do the call forwarding or let the physician on call have access to a specific phone for that. So again, a workflow for that and how it's all being documented on the back end, and making sure that the physicians who are covering call are also communicating. So for us, we did use a schedule. This was just an Outlook calendar, like everybody knew who was on call and when we were taking hospital call. But you need to have a call line workflow for these after hours issues. And then, how are you going to care for that patient? Are you bringing that patient to the office that evening? Are you scheduling them for early the next morning? How are you taking care of that patient? So if we're going to take care of this patient after hours and we need to see them, this is when that physician is getting in touch with the technician that's also helping support during that call week. So they're going to arrive to the building, like Kristen said, they're going to know where all the lights are. They're going to know how to turn off the alarm and open up an exam room for the physician, turn on the computer, make sure everything's ready to go, have the OCT machine fired up. And also understand how to use the equipment that we have. Can they turn the laser on? Can they turn the B-scan on? They're going to collect the patient info. They're going to get the patient registered in our EMR, and they're going to screen that patient for the physician. They're there to help assist during the exam if they need an instrument or a different lens. They're going to be kind of the feet running to get that. They're also going to assist the physician in getting that follow-up scheduled and checking the patient out before they leave. Or maybe they need to get sent, to the hospital for a surgery, which we'll get into in a minute. So after that visit, we need to make sure the next day that the surgery team is communicated to, that the appointment desk is communicated to, that the billing team knows that we saw a patient after hours. What if we need to obtain an authorization? They needed some sort of injection, something of that nature. And then making sure that they're following up the physician to close the loop with the documentation in the chart and those types of things. So if that patient during that after hours call needs surgical care, your support person needs to understand where to find the surgical paperwork and how to fill out the consent so the physician can get that signed and we can send that patient over to the hospital. Have they learned how to call the OR? Is there a place in the practice where the phone numbers for the hospital are posted? Is there a process? We always kept everything, again, in this on-call binder. I love the idea of one of those. With our EMR, our technicians used iPads. On iPads, they had Microsoft Teams, and in the technician channel, they have access to all of these files electronically. So if they weren't quite sure, they couldn't remember how to fill something out or where to find it, they could find it in that folder by doing a quick search. They also need to communicate to the billing team that an authorization may or may not be needed and alert the appointment team for any post-operative care that is then needed after the surgery. So a great way to do some of these communications is through our EMR. We had a task feature that made it nice to send a task to a team, and that way it was transparent for everybody that it was sent and that it was taken care of, and that loop is closed. So again, a lot of this is based around communication. So what if we are on hospital call? So there's a whole different level of protocol here. So the way it worked with our hospital was they had their own notification system that they used. So we had to communicate to them which of our physicians was on call and when, and the same with our other retina group in town. So there's a three-way kind of communication that went on pretty consistently to make sure they knew. So again, I mentioned earlier that all of this was kept on an Outlook calendar so that it was easy to see who was taking those calls. When we had hospital call, that was always documented on the correct month, and that everybody could see that and know the expectation. And then again, follow up on the hospital call. So if we were to see a patient in the emergency room or even inpatient in the hospital, our billing team needs to be aware because our physician can bill for those. So we want to make sure those pro fees are getting billed for the physicians, and again, that any authorizations are put in for the care that was delivered. And then follow-up care after that may be needed, just like Dr. Rapuano was saying, like we're going to see that patient for follow-up regardless of their insurance status. If they're late getting to our office or whatever it may be, we need to make sure we're accommodating that follow-up care for this patient. So it's really important that the entire team is aware. And again, we used Microsoft Teams a lot. That's a HIPAA compliant. We have a BAA with Microsoft so that we could discuss these types of things and let them know that we're expecting a patient from the ER and that we're going to get them in. So just some tips on preparation and how I can support the rest of the team. So Kristen, obviously, if she's making sure that we have people on staff that are able to support the physicians during the call week, then I need to make sure they have time for training. So part of this is making sure that time is taken during days where we actually have resources available to do so. I need to make sure that all of the resources are available to the teams. So again, creating SOPs. We had how-to videos of how to turn different equipment on, how to set the alarm when we're leaving and lock up the building, how to unlock doors. We made videos of all of these and they're available on our SharePoint drive. We love visual checklists. I like to laminate something and just have dry erase markers so they can just check off as they go and again, wipe it off for the next person to use. So visual checklists are great, especially because, this could be happening at night. We had a specific endophthalmitis SOP and a special endophthalmitis basket. So it had all the syringes we needed, all the needles we needed. It talked about gauze, iPad, whatever it is that needed to go in our endophthalmitis kit. We made a little kit for that, and it had a cover with the list of items that went in there. And on the back side, it had a alert to check and make sure that that patient was not allergic to any antibiotics before, setting all of that up, and to double check that with the patient before, in the middle of the night, we're then injecting an antibiotic. And then again, I need to make sure I'm providing strong communication platforms and transparency for the team. So again, these EMR tasks, Microsoft Teams, emails, whatever it may be, that there is a protocol and a process for everyone to follow in the different scenarios and make it easy for everyone to close the loop. So with the teamwork, I'm there to help with the contract negotiation, whether that's with the hospital or between practice partners on who's covering call, the team selection of who qualifies to be able to support the physician during call, and making sure that they're getting trained, that we have all of the equipment and supplies we need both in the practice and at the hospital. Being in a small town, they don't always have the retina equipment that we need, so we need to make sure that that is there. And if not, that we have some sort of go bag, like Kristen talked about, with lenses and lid specs or whatever it may be, and that we are closing the communication loop. So as a team, that we're taking care of all of these items and, again, supporting the patient in the care they need and making sure that our physicians can focus on giving the treatment to the patient. So I'm happy to answer any questions.
Jess, that was great. Thank you very much. No questions, but if people have questions, please put it in the Q&A. Just want to follow up on one of the issues from before. Most practices have staff who are on call, which is fine, but it should be clear to everybody that there's an ophthalmologist who is also on call if and when they're needed. I think all three of you have mentioned kind of documentation, which is obviously very, very important, not only for medical care of the patients, but also to decrease liability risk and also for billing. Now, the question comes up often, well, what if it's at nighttime or what if it's on the weekend and I'm a doctor taking call? I might not have access to my EHR, or if I'm on paper, I don't have my chart with it. How do I document that? Well, you can write a little note to yourself and then put it in the chart on Monday when you get back to work. That's fine. Some people have access to their EHRs on their phone these days. And that's even better. But a suggestion that was made to me, which I thought was great, was to actually send an email to your office manager. If your office manager gets in on Monday, they can put that email directly into the chart. Either paper chart, print it out in the paper chart, or just copy and paste it into the EHR. So it was done. It's time-stamped. On Friday evening, I spoke with Mrs. Jones, and she told me this. I told her to come in on Monday, but to call if there was a new problem or whatever. And then it's time-stamped for Friday night. It's not like a week later you put it in the chart when Mrs. Jones has a problem and she says, I want to come in, and you say, I told her to come in, but it's a week later. It's hard to kind of justify.
I actually love that idea. I think an email is great. It's easy, it's accessible, and the timestamp works perfectly. So, and sending it to your office manager, we're going to get it done for you. So,
exactly. If I send it to myself, who knows? It gets put in the back burner and may not get in for weeks. Yeah.
Well, I want to go over a few more resources. These are some of the ones we've highlighted throughout the talk. There was a brand new article that just hit the website, and it should be hopefully coming out in a future INET. And it's this QR code on the bottom left, the top myths about taking call and their reality, written by Matt Ball and Dr. Repka. So it's a great resource again. All of these are fantastic places to go when you're thinking about how do I bill, how do I document, what do I need to pack in my go bag. All of these kind of things, if you're setting it up or trying to improve your process, I think these are great places to start.
Well, terrific. I want to thank Kristen, Jess, and Grayson for doing a great job tonight. I want to thank Jill and Sean for kind of setting up everything here. And I want to thank everybody for attending. Thank you very much, and hope you have a great rest of the evening.